Thanks, Claire. Awesome. Well, thank you all so much for joining today. I am delighted and honored to open up our guest talk this month with Dr. Stephen Chen, a fairly new contact and friend of Climate Farm School, who will be sharing with us a little bit about his journey into a very unique role that he now has. So by way of a brief introduction, Dr. Stephen Chen is the chief medical officer at Alameda County Recipe for Health, which is a nationally recognized food as medicine program embedded in safety net community health centers that prescribes regenerative and/or organic produce paired with health coaching to treat, prevent, and reverse chronic conditions and food and nutrition insecurity. By intentionally sourcing food as medicine from local and BIPOC regenerative and organic farms, Dr. Chen has created a health multiplier framework called H cubed E, Health Cubed Equity, that generates co-benefits to human health, economic health, climate/soil health, and racial and health equity. Recipe for Health is one of California's first food as medicine programs to successfully utilize Medi-Cal and Medicaid to cover food and health coaching services. So Dr. Chen can tell us a little bit more about his journey that led him into this role. It's a super unique and beautiful story that was very captivating to hear. And I think where this is generally headed, in addition to Stephen's journey, is what role can doctors and physicians play in food systems transformation? And along those lines, what are the things that doctors and physicians and clinicians should know about food systems and farming practices to integrate all of these different frameworks that Dr. Chen is bringing together into their work and into community health. So with that, I will just thank you again for being here and pass it over to you, Stephen.
Hey, thanks so much, Lainey. Really appreciate the opportunity to come and share what's happening in Alameda County in the food as medicine space and the connectivity to farms. And thank you, Claire, for your support in making this happen. I have a question first for the audience. There's a few ways to do this. I could talk more about my personal journey up front, number one. The other option is I can share more about the work itself and what we're doing in Alameda County, so you have a framing of that, and then kind of go back into it in terms of how I came to that work. Kind of depends on how you all as learners want to hear the work and the time together, and how we want to spend the time together. So that's my question to you all. It would help me to understand who's represented here. I mean, I see the faces, not everyone, but if I could just get a sense of where people are you all health professionals? Are you maybe a one-liner? That would help me think about what would be most useful as we kind of interact today. So to kind of two questions, but maybe if we have time, Lainey and Claire, you all know each other, but I don't.
Yeah.
If there's a way for me just to understand who I'm speaking to, and maybe with one brief, like say your name, where you're located, and your professional background that brings you to the space, that would help me.
Totally. Yeah, I think we definitely have time to go around and share that. We're a relatively small group here. So yeah, we'll aim to keep things to a relaxed but brief, like 10 to 15 seconds a person. And yeah, let's kick it off with you, Kristen, if you're able to come off mute.
Yeah, good morning. Great to
Hi.
see everybody. I'm Kristen Coates, and I run a nonprofit organization called Regenerative California. And our big audacious goal is how might we make California a more regenerative economy? We're piloting our work in Monterey County as both the richest and poorest county in California. And central to Monterey County, of course, is food, predominantly conventional ag. We've launched a nearly 70-acre regenerative organic farm as a demonstration site. And there's a gentleman who I think you might know, Luis Diaz. Yes, okay. And he's been talking with me about a lot of the work that's going on around food as medicine. And we would love to provide food and be part of that programming and uplifting of this important messaging and practice.
Got it. Thanks so much.
Thank you. Should I popcorn to somebody? How about Shirley? Or is she frozen? I think she's frozen.
Shirley might be frozen. I can, if she, hopefully she can come back on in a minute. Shirley is an alumni based in New York, in Brooklyn, who co-founded a regenerative pasta company with another Climate Farm School alumni. And at the heart of it is distributing nutritious food to families through pasta that is locally sourced and whole grain. And it's very cool. I'll put a link to her stuff in the chat too.
Oh, there's
Um,
Shirley. Feedback.
Hi, Shirley.
Hi, I think my internet cut out. Sorry, it's a little loud. I'm in a Starbucks.
Oh, no worries. I'm going to kick it over to Amber, and then Amber, you can circle us back around.
Hi, sure, I'll go. So my name's Amber. I am working on a climate startup in the area of food, and its aim is to support regenerative farmers by educating and making regeneratively grown whole grains, nuts, seeds, and things made with those available to consumers. And I'm still investigating the idea in different ways. And this is very interesting because one of my ideas is to, kind of inspired by Daphne Miller, have healthcare professionals involved so that they can personalize some of these easy to store, easy to eat granolas and things made with whole grains. And I would say, in answer to your question, I'm curious about your whole program, and hearing about that first might orient well. And then, yeah, going on into how you got there would be really interesting. Thank you.
Sure.
Happy to jump in. Hi, I'm Elvina. I'm actually on a sabbatical at the moment. I'm from a finance background. I just did roughly 10 years in food media, and just have a real passion for the regenerative agriculture space. I grew up on a farm, so just trying to get the lay of the land of like what's actually happening right now, and trying to come up with ways that I could be useful in future. So just here to learn. Excited to hear about the program and your experience.
Alicia, you want to take it over?
To introduce myself. I heard about this event I think it was just last week, from Cal Velaton. He's an alumni of this group. And so I just kind of hopped on because we're partnering on an event, an in-person like conference kind of event called Anti-Burnout Summit, which focuses on social, physical, mental, and financial health. And so topics like creating my first career was as a chef, and I'm a dietitian, and I've created a Quick and Delish Life, which is basically a life-based accountability program with meal planning solutions, simple. And the Anti-Burnout Summit is basically about, reducing the risk of burnout in all the ways. And so I saw this as a potential collaboration. And I've gone to events like a food as medicine cooking class where like doctors get like a credential or whatever, and teaching folks how to cook simply. And like there's not enough like bandwidth in like the healthcare providers like time to make that happen, or the financial situation of like the cooking class spot. And so I'm like, I think collaboration is the new tribe's way. I've said enough.
Amazing.
Glad to be here.
Thank you for being here. Yeah, I'm not sure if anyone else is excited to chime in or is off camera. So maybe that's a sufficient sampling of the survey of the group. Yeah, for you to dive in, Stephen.
Great. So I'm hearing a request to start with the program. Any objections? Can we go there? All right. So I'm going to show my slides. Just a simple kind of slide deck to give you a sense of what we're doing here in Alameda County to frame this work. So tell me if you guys can see the cover page. Are we good? All right. Respiratory health sourcing, this is the key piece of our work in food as medicine, sourcing from regenerative and organic farms for food as medicine. So first of all, just what is food as or food is medicine? I like to use food as medicine. Others use food is medicine. Some of it's an East Coast thing versus a West Coast thing. I actually have a little more thought into the distinction why that preposition is important to me. I won't go into it now, but perhaps we can leave it in the conversation. Food as medicine is food-based interventions prescribed by healthcare teams. So this is kind of within the belly of healthcare awakening to the idea of using food as medicine, right, within our context. But for what reason? And that's really to do two things: to treat, prevent, and reverse chronic conditions and diseases, right? I like to say the reverse piece. I remember when I first started this work, maybe 10, 15 years ago, people are really, because we're so trained to just treat and maybe prevent, but often just assume people will be on medicines forever and it's just going to get worse. We're also addressing upstream issues like food and nutrition insecurity. And how we do this in California, as these definitions evolve, are in different ways. When we talk about healthcare engaging food as medicine, now we're really thinking about what is the intervention? How do you pay for it? What's the package? And so this is one way, not the definitive, one way of organizing interventions, one on the grocery side, one on the meal side. And then there's kind of a distinction between what is medically tailored here versus medically supportive meals, versus groceries, versus food pharmacies, versus produce prescriptions. Each of these mean different things, and it's evolving. Every state is kind of doing it a little differently. It's critical for us in our program to pair that with not only the provision of food, but the behavioral cooking and nutrition education. So my work in Alameda County, I kind of position it really as produce prescriptions. We define food pharmacies a little different than some of our colleagues in San Francisco. So with that, I want to show how food as medicine connects multiple determinants of health. So when I'm in clinic or when I'm overseeing the physicians and nurse practitioners and our RDNs and in our clinics, we're dealing with downstream patient coming to us with multiple conditions and kind of doing the typical thing. Food as medicine has an opportunity for us to do that in those 15 to 20 to 30-minute visits. We know that we're also addressing upstream issues, social determinants, social drivers of health, food insecurity being the prime example within the food space, but we're connecting people to each other through our groups. And so there's social isolation that's being addressed. By providing food that's really this high quality, regenerative and organic food, we're creating opportunities for jobs locally, and that can help with some of these other issues. We're also dealing with structural determinants. I'm very involved in policy work at the state and national level, and knowing that these structural determinants guide a lot of these social determinants, which then impact a lot of our patients. And there are a number of issues that we're dealing with here. And then finally, what's so powerful about food as medicine is we have the opportunity to deal with the ecological determinants of health, right? How we grow our food impacts soil loss, which can impact, and also how we use water, which can impact all of these other pieces. So food as medicine is different than just a pill, right? It's not just a pill that doesn't have these other benefits. And that's what's so powerful about this food as medicine moment. So the challenge is this, right? What are we faced with in healthcare? We're faced with an unhealthy, and the nation, we're faced with an unhealthy diet being the #1 driver of mortality. It is fundamental to all the different conditions that we deal with in clinic: hypertension, diabetes, heart disease, et cetera. We're talking about 500,000 deaths per year. It's higher than tobacco, higher than diabetes, higher than a lot of the other, quote, diseases, because it's at the root of many of these conditions. 60% of our adults have a chronic disease. Now, that's an understatement because disease is so downstream. We also have conditions like hypertension, prediabetes, that are not always encoded in this disease. A lot of our patients have these chronic conditions that are prior to the disease element. We know that food insecurity, especially now facing all the cuts to potentially SNAP, this is a dangerous thing for us in healthcare, because if we don't address food insecurity, we know that the risk of developing chronic conditions increases. And I'll just give the example of diabetes, a twofold risk. And then our healthcare system's paying 4.9 trillion a year. We're just spending it left and right. Every year we're spending, and it goes up every year. Now, on the ag side, 90% of our topsoil is going to be lost within 30 years by some predictions. We know that decreased soil health leads to decreased nutrients in the food. There's a lot of interest in that. Increased pesticides, waterway pollution, and then the agri-food business. This sector is leading to 31% of greenhouse gas emissions, right? So this is a big deal. Now, you are all climate farm school folks, so you all probably know all of this, but I want to just kind of level set what we're up against from the health side and then from the ag side and how it comes together. So food as medicine is that solution. I think a solution that can, especially if it sources food regeneratively and organically, it has these opportunities. So the question that I want to put forth is, again, as a healthcare person, will healthcare transform or reinforce the agricultural status quo? What I mean by that is, if we in healthcare are spending, and I need to update this slide because I realize this is my 4.3 trillion, but I just shared that it's 4.9, right? If we're spending 4.9 trillion a year and 90% of that is used to address chronic disease, 3.9, that's a lot of money. Now, since you all are climate farm folks, I'm going to ask you, how does this compare against the Farm Bill? How much money does the Farm Bill bring us every year? Anybody? No worries. I'm just gonna just put this number, this list, the relative small percentage, right? The Farm Bill is politically contested. It supports a lot of subsidies. It's important, but it's a lot of money. It's 86 billion roughly. That's a lot of money. But relative to healthcare, tiny. So I think healthcare is a sleeping giant in terms of funding and the chance to change the course of conditions for our patients and those as well as communities. So that's the level set, y'all, in terms of kind of where food as medicine fits. Let me go into our work that we're doing in Alameda County. We call it Recipe for Health. That's our food as medicine program. We've gotten some national awards. We've had the former HHS secretary come and visit and do Food as Medicine Roundtable. Barbara Lee's been involved. So there's been a lot of attention and looking at our model as a potential way to shape food as medicine. So let me share with you then, what is Recipe for Health? So I like to say it's, simply at the end of the day, if you're my patient, each of you are one of our patients at our clinics, it's pretty simple. It's food and health coaching. It's produce boxes specifically, and we're using it to treat, prevent, and reverse chronic conditions and food insecurity. We're doing the both and. We're not just doing chronic conditions. We're not just doing food insecurity. We're saying in the healthcare context, you come to me as a whole person. Let me take care of you as a whole person. Now, what does this look like? For us, the food is not just any food. It's not Safeway food. It's not, no shade on Safeway per se, but it's not conventional food, right? We are very specific on local, organic, regenerative, and from BIPOC-led farms when possible. We partner with Farm Fresh 2 to do some of that food hubbing and aggregation and then distribution. And we're providing weekly doorstep deliveries of this food. So if Elvina, if you're one of my patients and I write you this prescription and you want this for your diabetes, the food will start coming to your home weekly as a box of this and with a recipe. You'll have an option to join health coaching. This is my former clinic when I was a medical director at one of our safety net clinics. You can see a demonstration kitchen in the back, teams broken out in small groups. This is our nutritionists. We have health coaches. We're doing movement with a movement coach, nourishing around food, connecting in small groups, and mindfulness practice. And this is 6 weekly sessions by our team, Open Source Wellness. They are a nonprofit. They're willing to scale and work elsewhere. How do we do this? How do we provide all of this? We have a recipe, like any good recipe. And that recipe has 5 ingredients. That first ingredient is the safety net health centers. The second ingredient is our food pharmacy. And I'm going to go through each of these with a slide, and then we'll finish, and then we can talk. And then the behavioral pharmacy. So notice how food pharmacy and behavioral pharmacy, notice the word, the pharmacy piece. And so let's just say Kristen, you're one of my patients, and I prescribe you a blood pressure medicine. Where are you going to fill that blood pressure medicine?
Pharmacy.
I think it,
Yeah, you're going to go to a pharmacy. But what happens if you don't have a pharmacy nearby, or you don't have insurance to pay for that?
I won't take it.
Yeah, you have a hard time kind of fulfilling my prescription for your health to manage your blood pressure, right? So pharmacies are convenient, they're local, they're available. Hopefully, if you have insurance, they cover you, right? It's a kind of a delivery system to make sure you can fulfill my prescription for health. And yet, every day in our clinics, we tell people to eat healthy, go take care of yourself, your mental health. And we say, I'll see you in about 3 to 4 months. And we wonder, why has there not been a sufficient change? It's because we're writing essentially a prescription to nowhere, because our patients, especially our most underserved patients, may not have resources like a pharmacy where they have access to this type of food as well as health coaching. So we also have a Medicaid health plan, which helps fund using Medicaid dollars, or in California, we call it Medi-Cal, to pay for these food boxes and health coaching. So it's a free service to our patients, our most vulnerable patients. And then the chef, if you will, in this whole ingredient list is my team. So we at the county are the backbone. We're the training and administrative hub that support the health centers, do all of the interconnections so that when docs are in clinic, or nurse practitioners, or RDs, or behaviorists, they do what's best. They take care of the patient, and they can click the buttons. And in the electronic health record, we connect with the food pharmacy, the behavioral pharmacy, and put it all together into this delicious recipe for health for our patients. So that's the recipe for health kind of operations. The DNA of our work is what we call, where we say recipe for health is a health multiplier. We are encouraging all food as medicine programs to really think critically about their sourcing. Where do they buy their food? And the question is, where does the food come from? Once you ask that question, you create a cascade of other questions. Who's growing it? Is it fair? How are they growing it? So we know that healthcare demand for local regenerative organic food from BIPOC farmers creates a driver, generates these H-cubed-E co-benefits, right? So, health multiplier, you think of it as a multiplier. So I got a little nerdy here, and I pushed the H-cubed-E to help highlight that there's a multiplier effect. I'm a doc, so I'm going to use health. There's a human health benefit, a climate and soil health benefit, and economic health benefit. And those are the 3 H's, and then the E is the equity. And I know that equity is a dirty word right now, but this is just, before this became a thing, and now it's out of fashion, we've been doing this, right? And many communities have been doing this work for hundreds of years, right? There's always been an equity piece to folks in our country trying to make things better. And then I think if we do not raise the question of where the food comes from, we will run into an economic race to the bottom because of our system, because of how we finance and kind of do profit and loss in our country, in our kind of economic system. Let me just give an example of warning, right? If we don't do this right with food as medicine, pay farmers well, pay for the food, and ensure that food can be accessible to all, we face this situation. I have twins. They're 11. They just finished 5th grade. They go to public school. This is what they can get for breakfast. A free breakfast at public school. Frosted cornflakes, tricks, everything processed, ultra processed food. This is a metabolic bomb about to happen in their lives as they eat this every day. They will show up in our clinics with fatty liver, with prediabetes, and then eventually be unhealthier adults if this becomes the way they eat. This is because of the system we've created for our schools. We don't want that for healthcare. That's why I'm saying, is healthcare going to be a status quo reinforcer, or is it going to help transform our food systems? So I'm going to do a quick run through of the 5 ingredients in visual form. This is Alameda County. So, you know, it's east of San Francisco County. It's 1.7 million people in this county. We have 100 languages spoken in this county, one of the most diverse counties in the nation. A big landmass, you know, from Oakland, for those who don't know, you know, where Alameda County is. We have the city of Oakland, UC Berkeley for the city of Berkeley. We have 5 different health organizations, and they have subclinics. And so that's our footprint. Our patients, 83% BIPOC, majority Spanish speaking. You can see the breakdown of the various ethnicities and races. Our second ingredient, we are partnering. We used to have a hyper-local farm called Dig Deep Farms. Now we're partnering with Farm Fresh to You, more of a network of farms and food distribution. And so we call that the food pharmacy. We're trying to really create pharmacist roles, living wage job roles. We're growing food, BIPOC, regenerative and organic farmers, no pesticides, soil health, higher nutrient density. We're delivering no longer bags of food. It used to be bags of food with Dig Deep. Now it's boxes weekly. And then it's doorstep delivery, which is fantastic. It really creates a higher redemption rate. You don't have to have patients come in a clinic, go into a food pantry, trying to figure out where their food is. Farm Fresh to You, they're a network of 95 farms in California. I'm just going to highlight Jazz Family Farms. Kristen, you may know them because Tony and team, I think, are connected to Luis.
He's an angel.
Yeah. BIPOC-led regenerative organic since 2014. They're really rehabilitating the land. Salinas, 406 acres. And so we have a network of a number of farms that are we're sourcing from for our produce boxes weekly. The how, I kind of talked about this earlier. You know, in primary care, we're always telling people to exercise more, eat better, reduce your stress, get some social support. And then we wonder, hey, you come back in 4 months and then we're like, what happened? A lot didn't happen for a lot of our patients, right? There's no plan, there's no resources, but limited support. So that's why we developed this behavioral pharmacy for group and individual coaching. We have health coaches that help staff these groups. I've run groups where I see 12 to 24 patients per half day. That's like incredible. Most of us see in primary care maybe 18 in a day if we're lucky, because it's so, you know, it's busy, it's tough to do. But I see a higher volume in a small amount of time. I have more fun in terms of burnout. You know, I think, Alicia, you were talking about burnout. I'm having more fun doing group visits than just kind of the rat mill of just seeing patients one by one. The joy is back, you know, in terms of seeing patients in group, because everyone's benefiting each other. We're moving together with movement coaches. We are talking about the food, that the kale or the collards. You know, I'm Mexican, you're South Asian. How do we talk about this food that we've never seen? What spices do you use? So there's a lot of cultural exploration of the food. We're connecting in small groups with health coaches assigned to each table, and everyone's learning from each other, not just from the doctor or the nurse practitioner or the RD. We are doing mindfulness practice. It's a fourfold approach to taking care of our patients, to amplify the effect of the food, to sustain the effect of the food beyond the prescription. And we do this in health centers. We do it at the county in terms of county-wide groups, and we also do some individual coaching. I'll get to the 4th and 5th, and then I'll close. Medicaid health plans and the CMS. This is getting a little policy wonky, but you know, in order to sustain things, you got to figure out funding pathways. And so Medicaid health plans, you know, there's a health plan in each county that is there to ensure that our most vulnerable patients have access to some basic health care. CMS is Centers for Medicare and Medicaid Services. It's the national, our central hub of all of our healthcare. And the 1115 waiver is this, you're going to hear about it if you're in the food as medicine space. What's a waiver? And so a waiver is a mechanism, it's a policy mechanism which allows states to create innovative demonstration projects to improve Medicaid. Normally, historically, healthcare is not paid for food. Because we've been able to pitch, and this part of the policy work I was doing, pitch healthcare as innovative to improve Medicaid services, there was a waiver at the federal level to allow states to use funding to pay for food. So the question is, what kind of food are we going to pay for? So in California, Medicaid managed care plans, and this is ours in Alameda County, they can opt in to offering cost-effective alternatives to traditional medical services that are designed to address social drivers of health. So in the policy language, you call it medically supportive food. I call it food as medicine. It's paired with behavioral, cooking, or nutrition education. The fifth, and this is what it's looking like at a scale level, right? So we're one of the first in California to pull this off for produce prescriptions. There are 13 other states that are approved to use food as medicine and 3 others that are pending. Last ingredient, the training and administrative hub. A lot of what I do and what we're trying to do with this model is to expand mindset. So most of us doctors, so I trained, I trained at Stanford and UCSF and did a fellowship with Andrew Weil's team in integrative medicine. I had 0 training on using on nutrition and how to use food as medicine in medical school. I had 0 training in residency. I got some training with Andrew Weil's program. And I talked to, and I trained 25 plus years ago, and I talk to young clinicians now, and they are in the same boat, minimal training. Now, I also know that we have RDs that have a lot of training in this work. One of our health centers has 0 RDs across the whole health center, across our 10 to 11 sites. So part of it is we don't have enough RDs in the space. And then also, how do we get it to everyone, right? So I'm very committed to ensuring that everyone who comes through our health system, that the clinicians, doesn't matter if you're an RD, a physician, a nurse practitioner, a behaviorist, that you get some fundamental training on how to use food as medicine to treat and to support your patients. We also train medical assistants. So I train the medical assistants on screening for food insecurity in a culturally humble way. And then we also integrate in SNAP so that we're not only just doing the medical side, but we're also doing the social services side and bringing in SNAP, CalFREC to help improve enrollment to food stamps, what was so-called food stamps. And then my team does this. This part in red is the non-sexy, heavy lifting work in order to make this recipe for health happen. It's really detailed electronic health record design. It's working with the clinics when they have limited time to make this as effective and efficient as possible in terms of the workflow. It is doing the back end referral, prior authorization. You all have heard about authorizations. You go to your doctor, you need an authorization from your health plan. It's really a pain. That's why there's a lot of anger at health plans. We take that on so the docs, the nurse practitioners, the nutritionists don't have to fill those forms out. We manage all of that in a streamlined way, and then we can then pull down the funding. So that's Recipe for Health. I've trained, this is an old slide. I think, we're now at 11, we're still at 11 sites, but I've probably done 70 trainings by now, probably 400 staff. At the time, 865 attendees, and we had a net promoter score in terms of our trainings, our curriculum of 95%. Would you recommend this training to your colleagues? Final thing, I'll just say something about results. This is just a story of a Tammy, one of our patients, our early patients at Hayward Wellness, which is where I used to be the medical director. She said, my doctor told me about food as medicine. The first group gave me hope. It literally saved my life. It gave me my spark back. I started to care about myself and about others. Actually, I'm going to ask one of you guys to read because I'm talking too much. So Shirley, why don't you read this one?
All right. Before, I was overweight and my blood pressure was sky high. I had stomach problems. All of that has cleared up. I'm walking. I'm doing the online Zumba classes. My blood pressure is within normal range, and I'm working to get off my medication. I've lost 77 pounds, and I'm still going strong. That's awesome.
Great. So, thank you. In terms of our reach, this is an old slide. I need to update it, but at the time, we'd served over 7,100 patients, 90,000 bags of food, almost 1.5 million servings of this regeneratively and organically grown food. In terms of patient outcomes, we're improving health behaviors. You may think a 0.8 serving increase of vegetables and fruit per day is not a lot, but I just want to help you all contextualize it. One serving, fistful of your vegetables. They don't have to be cooked, just kind of a stack of vegetables. That's a 5% reduction in all-cause death. all-cause mortality. So your chance of dying of anything, regardless of diabetes, cancer, whatever, is reduced 5% for every increase in serving of vegetables. That's why we get to the 5 a day, and we get around 25%. This is based on epidemiologic data. We're increasing physical activity almost 40 minutes a week. Now, this is all during COVID. This data is during COVID when we were doing this model. Our Stanford and UCSF evaluation team looked at this. We're improving mental health, 44% reduction in depressive symptoms, 32% reduction in anxiety. We're reducing chronic conditions. A third of our patients with diabetes and prediabetes showed an improvement in their A1Cs or sugar metabolism. 2/3 of our patients showed improvements in lipids, like their total cholesterol, although we're not as worried about total cholesterol, but some of the elements of our cholesterol panel by at least 10% to reduce heart disease. We're improving food security. 67% reported food security after 3 months. And then healthcare costs, 15% reduced likelihood of emergency room visits compared to control group. So that's it. I'm going to pause and we can get into the fireside part of the chat. First of all, take questions, reactions. Did we lose Lainey?
Yeah, Lainey had to hop off and to be able to catch a flight, but she's excited to catch the rest of it. But
Shirley?
Yeah. First, I want to say, like, this is so awesome to see. I'm a huge believer in food and food as medicine. And I actually worked at a health tech company maybe 5 years ago where we wanted to do some kind of like produce prescription box, but our main payer partner was Anthem. And I think they were maybe a little more risk averse at that time. So I'm actually curious to hear a little bit more about your relationship with Medicare and if are there specific outcomes or like engagement thresholds that they're looking for from you or any other requirements for your program to continue qualifying for, I think it was like CMS 115. And what is your long-term plan for funding? Are there any opportunities for earned revenue or is it primarily donation and grant based?
Sure, great questions. CMS, so it's not Medicare. Medicare is for 65 and older. It's Medicaid or Medi-Cal in California. So it's for our folks who are under certain poverty limits, in terms of income. So we, in terms of engagement, this is part of this personal part, right? Like, how do you put together something like this? It takes a lot of different forces to happen to make this happen, right? And so, when I was recruited over to the county from working in the health centers, I was recruited over by Supervisor Wilma Chen. I'm going to get to your question, but I think it's from a storytelling perspective useful for the group to understand the origins. Supervisor Wilma Chen, unfortunately, was hit by a car and has passed away. But she was a champion for this work. There's 5 county supervisors in all of Alameda County. Every county has supervisors. They are the people that make the decisions at the highest level. She heard about my work in 2016. She asked me to testify, if you will, to the county supervisors. And I kind of gave a presentation of my early work. And at the end, I threw down the gauntlet in 2016. And I said, imagine the day when healthcare is transformed and this food as medicine stuff is covered as a prescription, just like any other prescription. It's just covered. Okay? The food and the health coaching is paid for, just like the blood pressure medicines. And then I left and I kept on doing the work. And then in 2019, she recruited me over to the county level and said, I want you to help build food as medicine across the county. And I said, okay, cool. That's interesting. What's your vision? She said, I want you to help me work with it at the state level to get this into policy, and I want you to help take this nationally. So part of the healthcare engagement work, Shirley, was because she was a county supervisor, she set the table and brought in the health plan. The CEO of the health plan understood when a county supervisor wants to get something done and invite you in, you do, right? I mean, because they're going to unlock funding. So the health plan, the CEO of the time understood this moment. And so he invested in the early days of piloting this work because he saw that in 2022, the CMS waiver that I talked about was going to happen. And so until 2019, when I was recruited over, he began to invest, offering funding to help build the operations beyond what I had done at one health center to expand it across other health centers. So that initial piece already showed the engagement of the health plan. And that led to then it becoming us preparing for this 2022 moment when federal dollars could be unlocked, right? We also were working with Anthem at the time, but then our county made a decision to just go with one health plan. And so Anthem is no longer part of our Medicaid offering. But in terms of other outputs for what they want to see engagement from the patients. They want to see all the traditional metrics of health outcomes. So that's all kind of baked into our work. In terms of, what's the funding pathway for the future? I'm a county, I'm not trying to make money off of, it's not a business, it's a business in the sense of operations. And I want to pay for everything, pay our partners. Like I see our role as the government is to bring in the funding to pay the community-based groups on the ground who are doing the work closest to the patients. Because we're not doing it. We're not creating our own like county employees to do this. We're saying, who in the community is doing this? How do we get funding to you to do this? Medicaid is part of it, but going after grants is another. And so Medicaid doesn't cover everything. I'm very clear that I want to cover our food insecure patients. Medicaid does not cover food insecure patients. It'll only cover patients with chronic conditions. So that was a long answer to your question, but I'm trying to blend in the personal stuff too, some of the storytelling stuff. So other questions? Kristen.
Thanks for that presentation. If you feel comfortable, I'd love to have a copy of your deck. But my question, thank you for that. My question is, in terms of adoption by other healthcare providers, how has that been received amongst the community? And are they also as excellent as you in getting it out there?
You're saying in Alameda County or outside of Alameda County?
Well, I guess, yeah, good. I mean, as I look at that map of what's happening across the country, I mean, there's some real movement there. So I guess Alameda probably is what you can speak best to, but if you do have intel on what's happening nationally, I'd be really curious.
Sure. I mean, I'll talk first locally. Alameda County, it was again, Supervisor Wilma Chen bringing together the health center CEOs and saying, this is a direction we want to go. So once you have alignment there, then it creates an open door for me to work with the other chief medical officers to say, how do we execute? So, but not every health center is ready. They're busy doing other stuff. But once we're in and partnering, the clinicians love it. So adoption's easy because it's one thing to tell clinicians what to do. It's the other to build it for and to build the system for them so they can actually do it. You got to do that. If you just tell them, oh, there's free food or there's whatever, it's all cool. They're like, great, but I have 10 minutes. How do I even think about this? So the fog of care is real. And I work with them on training them and then creating the mechanisms so that it's doable. In terms of outside of Alameda County, there are a lot of programs out there trying to do different elements of it. I shared the beginning slide, medically tailored meals, lots of medically tailored meals people doing that work. There's people doing produce prescriptions in San Francisco. So there's different players. I think what makes us a little unique is we're actually healthcare driving this. A lot of my colleagues in the food as medicine space are CBOs who are in the food space, and they're trying to figure out how do you get into healthcare, right? How do you create those referrals? Well, I'm a doc, so I can easily talk to other docs. Docs are kind of this breed of a siloed breed like any other healthcare. Like they don't listen to other people very well, right? They often need to hear it from another doctor who has positional authority. So I just leverage my positional authority to kind of get in there and share it.
Can I ask one other follow-up question? I don't want to dominate the space, but just real quick in terms of, because we're a farm, of course, in Salinas and would love to provide food. We can take it offline, but if there's someone to speak to or with about that, I'd be very curious.
Yeah, sure. Happy to talk offline.
Thank you.
I have a quick question.
I just wanted to go ahead.
Sorry, my quick question was what do you think the hurdle might be for this to have greater adoption? I guess is it with doctors that need studies to prove that it's successful, or is it the infrastructure build out? I'd love your perspective on that.
I think it's more the, I mean, there's a number of hurdles, but one of them is if a health plan is ready and a health center is ready, the connectivity to the farms or to the distribution and to the mechanism, knowing how to do that at the level of every patient and tracking it, that's hard, right? If you're going to use Medicaid, that's highly regulated. If you have grant funds, do it however you want. But if you're going to do Medicaid, that's a big hurdle. That's why we at the county took the role of being this administrative and training hub. Otherwise, the opportunity would have been every farmer, every health coaching organization trying to come up with a billing mechanism, with a referral mechanism. And that's kind of what's happening. It's very American, right? We kind of decentralize it to everyone, and they just kind of, hopefully someone figures it out, and those who get funding and hustle, they get it. They can win the whole thing. But it's very inefficient, because what we've developed, we could do, if there was enough, if there is alignment at other levels and funding, we could take this model wherever, right? It's not that hard in terms of the 5 ingredients. The hard part is the building is the operational work. People can convene all they want, have practice learning groups. It's all great. But when you're in the weeds of actually negotiating with health plans, working out the electronic health record, all of that, building the connectivity, that's like work. And so that needs labor, that needs thinking, that needs funding to make that happen. So I think that's one of the big barriers. I think the second barrier is mindsets. That's why we try to train our clinicians to make it easy for them to see that food can be a powerful medicine. A lot of clinicians don't have that training. And some of my RD friends have criticized the whole RD training, as well as I criticize medical training. That is very traditional. It's very industry folk. There's an industry bias. It's not necessarily as integrative as kind of focused in that way. So.
I just wanted to thank you for the presentation, and I look forward to meeting you at some point. I'd love to talk about, ask you, who you know in the dietitian field, and see if I can connect you with people that you don't know. I might know some people. And I'm super jazzed and look forward to more of this. Aren't you all excited, everyone?
Thanks. Appreciate
Thank
that.
you. I'm glad I took the time.
Thanks for joining us. Diana, oh, sorry, go ahead.
Oh, I was just going to say, if anybody wants to connect with me for any reason, I put my information in the chat, and then I'd love to connect with you, Stephen, as well.
Sounds good. I think Diana and then Amber.
Yeah, thank you, Dr. Chen. My name is Diana. I'm actually an RN case manager at Oakland Children's Hospital. Nice. I joined the call a little bit late because I'm actually driving to a strike that I'm not sure if any of you are aware. Like we are striking, all the nurses, the RDs. Actually, the doctors are probably the only ones who aren't striking right now, because UCSF is merging. We are merging with them, and there's a lot of problems with this happening very shortly. So I can't help but think of, I love what you're doing. I actually left bedside nursing to study regenerative farming on the Big Island of Hawaii, and also just cultural medicine and how we can better integrate that into our healthcare systems. My question really is more focused around like the deeper conversation of the healthcare system change, and how we can address not only like the climate issue while addressing our health issue while supporting small farmers, and really think about economic systems that are very different, that actually empower doctors and nurses and RDs to have ownership in the system, while they also make the decisions of how they treat patients and what that looks like. So I'm curious if this is something on your radar, or because there's a lot of local projects that I'm working on in my area. around building a food hub that is a clinic that prescribes medicine, that also supports small farmers, and how those all can be woven together to serve the community, where we are actually moving away from needing to go through insurance companies, building cooperative business structures to build generational wealth. So I'm just curious about that aspect, and how we can co-create that together, because what you're doing could really feed into what we're doing, and where those opportunities might lie. Thank you.
Yeah, Diana, that's a really powerful vision. I think that we're not there yet, right? We're using the existing system and trying to leverage the existing system in terms of the larger vision you have, of creating a cooperative of all physicians or health centers. We are working in health centers. We're using the existing FQHC system. As an FQHC doc, I've never owned the practice, right? And I actually don't want to own the practice. I'm not in the business side. I just want to take care of patients. So if that's what you mean by cooperative, I think the physicians historically have had challenges around that within these large insurance systems, because we're part of a large insurance-based healthcare system as opposed to say single payer. My family's from Taiwan. Talking personally, I was born here. My grandfather is a farmer and was a farmer in Taiwan. The Taiwan healthcare system is an incredible single payer system with incredible satisfaction rate. Even there, it's moved away from ownership, right? They're all part of systems. So just from the healthcare side, but from a food side, for sure. I have colleagues down in San Diego that are creating farmer collective food hubs, where they own that, and they drive the means of the production. They share that and they connect in with our healthcare system. I think the healthcare system is a bit behind, right? Or it's just a different model, have to think about how to do that. It's a larger question, but I think certainly the piece on ownership by farmers is what's potentially possible with food hubs, as well as them working together in collectives. I do have a 10 o'clock call too. I know Amber has a question.
Yeah, I have a 10 o'clock as well. So I just wanted to say thank you. This is amazing. It's all the data is there. It's just we need people like you who are just getting out there and doing it. And I love the holistic approach of bringing in the mindfulness and lowering stress, and just just the whole deal is just amazing. So thank you. And I'll just put my question off and connect with you some other way, because I do have some questions about the food and what you found about whole foods and whole grains, and the reasons you didn't integrate that in. And yeah, I'd love to connect with you.
Certainly.
All right. Well, thank you all for coming, and thank you again, Stephen, for joining us today. I think you are doing some really amazing work at a really niche and important facet of the healthcare and food system space. So I appreciate you taking the time to share and for all the thoughtful questions. Thank you, everybody.
Thank you all for this, and glad you guys are learning together and creating that connection between climate, farm, and health. Take care.